I'm thrilled to invite Dr. Jennifer Nayor for our penultimate lecture. Jen came to us with a really impressive pedigree, as you can see in the handout, to Emerson in 2020. And she and I share many patients and I think exemplify some of the multidisciplinary work that you see at Emerson. Because it's a small place, we can really collaborate and work together to deliver the best patient care. So I'm thrilled to invite Jen to the podium, and also quick round of applause, congratulations, because you were recently named the chair of medicine at Emerson.
Good evening, everyone. Thanks for taking some time out of your days to spend with us. We really appreciate you being here. So I'm going to talk about 3 common things that I see in my female patients. My slides have nothing with menopause. We've heard lots of things about menopause. I don't have menopause listed a single place in my slides. So these are just common GI things that we're going to go through. So these are kind of the top 3. So the first one I'm going to talk about is gastroesophageal reflux, or GERD. So the common symptoms I'll hear, so heartburn, chest pain, sore throat, throat clearing, chronic cough. So sometimes acid's coming all the way up into the throat, and that's what I'm hearing more than the chest symptoms. So what's happening with acid reflux? That's this picture here. So normally your stomach has acid. That is totally normal. That is what is supposed to happen. When it's problematic is when that acid goes up into the esophagus. So you naturally have a muscle at the bottom of your esophagus that prevents that from happening. And in some people, that muscle doesn't work quite as well, and you get acid reflux. There's also kind of a close cousin to GERD, which is dyspepsia. And acid can be a reason for dyspepsia, but the symptoms are a little bit different. So sometimes people will come to me with symptoms like nausea or upper belly pain, bloating, belching, indigestion. They feel full kind of quickly. So sometimes these symptoms are related to acid, and sometimes they're related to other conditions. So what are the risk factors for GERD? So diet, that's probably the number one thing. It's the number one thing I do counseling on in clinic when someone comes to me for a symptom of heartburn. So what causes it? So acidic foods, tomatoes, oranges, vinaigrettes. I'm sure we've all had this experience when eating something very acidic or drinking an acidic seltzer water, something like that. Greasy foods, so if you go out for a hamburger or a pizza, nachos, common to have acid reflux after. Other ones that people don't think about as much, so chocolate and peppermint. So peppermint actually relaxes that muscle at the bottom of the esophagus and can be a risk factor for acid. Other kind of common things, eating right before you lie down at night. So if you eat dinner late at night and then go lie on the couch, you're most likely going to have some acid reflux symptoms. So it's good to sit up for a while after you finish eating. Other things, so obesity and pregnancy kind of go in the same category. So the more weight you have around the middle, acid is more likely to travel up. Smoking, and then hiatal hernia. So this question comes up a lot in my practice. So what is a hiatal hernia? So that is that normally your stomach is all in your abdominal cavity. A hiatal hernia is when your stomach pops up into your chest cavity above the diaphragm. So your stomach is now up here in your chest. And that's a risk factor for acid, because now your stomach is above the diaphragm, which is a natural blocker at that connection, and people can get more acid reflux symptoms. So when do you worry? So I just said, like, everyone gets acid reflux. I'm sure everyone in this room has had acid reflux at some point in their lives. So when do I start to worry? So when things are getting stuck. So if you feel like you're eating something and it's not going down easily, to me that's worrisome. That's definitely a reason you need to come see me. If you're losing weight, so your acid reflux is so bad and you're not able to eat and you're losing weight, that's a red flag sign. If your symptoms are acutely worsening, if there's rectal bleeding, or if there's a family history of Barrett's esophagus or esophageal cancer, those would be reasons that you would probably want to come see a gastroenterologist. So how do we treat acid reflux? I just talked about some of the risk factors. So a lot of these are related to the risk factors. So maintaining a healthy weight. Anti-reflux diet, so avoiding those foods that I just spoke about. Minimizing non-steroidal anti-inflammatory medications, so Advil, ibuprofen, Aleve, those can cause some acid reflux type symptoms. And then medications. So if you go to the pharmacy, if you go to your Walgreens or CVS, you are going to see an entire aisle of things that are used to treat acid reflux. So I just wanted to kind of simplify this for people so they know what they're buying when they're purchasing over-the-counter antacid medications. So the top list there, Zantac, Pepcid, Tagamet, those are some brand names. Those are H2 blockers. So those are histamine blockers, and they are really good medications to control intermittent acid reflux type symptoms. You can take them occasionally. Sometimes I say if you're going to go out and eat those nachos and drink a beer, maybe you want to take one of these beforehand if you know you're someone who's predisposed to acid kind of symptoms. Sometimes people are on these more chronically. However, they usually start to lose their effectiveness over time. So sometimes they don't work kind of for the long term. The next box down, so the Prevacid, Nexium, Prilosec, so those are some brand names of proton pump inhibitor acid blockers. Those are stronger acid blockers. They've been over the counter now for a few years. They work really well. They've gotten somewhat of a bad rep. So if you go online and look up proton pump inhibitors or PPIs, sometimes people say, you really don't want to take those. There are a lot of downsides. The major thing I counsel my patients on is osteoporosis risk. So we've already heard about acid reflux medications causing osteoporosis, and the issue is that you're not absorbing calcium and vitamin D the way you should if you're on these medications in the long term. So sometimes I'll try and get people off of proton pump inhibitors and steer them towards histamine blockers instead. The last picture there, so Vonepezan or Voquenza is the brand name. That's a new acid blocker that's come out for refractory esophagitis from acid reflux. So it's new to the market pretty recently, and it suppresses acid levels even more, and that's a prescription medication, but carries the same risk as the proton pump inhibitors. So now we're going to switch gears, and we're going to talk about the lower end of the GI tract. This slide has a picture of poop, and if that offends you, close your eyes, but I'm a gastroenterologist, and this is what I do every single day. So this is the Bristol stool chart, okay? If you come to my office with bowel issues, you will probably see this chart because we're going to talk about your poop. That's what I do. So this is kind of what normal stool is and where people go on either end of it. So in the middle is a Bristol scale type 4. That's a normal log or sausage of stool. And then as you go up, you head more towards constipation, and as you go down, you head more towards diarrhea. So I'm going to spend most of my time talking about the constipation side of this scale, because that's honestly what most women are coming to talk to me about. Some people go the other way, but I would say constipation is usually more common. In terms of etiology of constipation, there are a few different reasons people get constipated. Sometimes it's slow transit. Things just are slow moving through the gut, right? So when we are less active, the gut slows down. The gut is a muscle. So we have to stay active to keep that muscle going. And so it can slow down and there can be slow transit. The other really common reason that I see women for constipation in my office is pelvic floor dysfunction, and we've heard a little bit about that and physical therapy. But what pelvic floor dysfunction is that normally when you have a bowel movement, the rectum contracts and the anal muscles relax. And sometimes in women, that doesn't work the way that it's supposed to. And the rectal muscles will contract and the anal muscles will contract, and you're basically pushing against a fixed opening, and you don't get an easy bowel movement. So women will come to me and say, I just feel like I can't push out a bowel movement. And women are more at risk. We have more pelvic organs, pelvic surgeries, C-sections, so women are at risk of that kind of constipation. But the management to begin with, the kind of baseline stuff, is very similar for all types of constipation. So constipation, decreased stool frequency, straining with bowel movements, incomplete evacuation like I was just describing. And we talked about some of these risk factors here in different kinds, so slowed peristalsis, immobility, not drinking enough water. Everyone needs to drink more water. I'm sure none of us are drinking enough water. Drink more water. Medications that slow down the GI tract, and then decrease or lack of muscle tone in the bowel and abdominal muscles. So again, reasons that I get concerned, rectal bleeding, weight loss, family history of colon cancer or inflammatory bowel disease. Those would be things that I would be, kind of a little more attuned to and a little more concerned. So how do we treat this? So I just talked about water. So I tell my patients 8 to 10 glasses of water per day. Fiber. We've heard a lot about protein. Laura's going to tell us more about diet. But fiber is also super important. The two things that I'll say, like in terms of like something just helpful if you have a bout of constipation when you're traveling or something, prunes are super helpful. Kiwi, there's a study in the New England Journal, eat a kiwi, and it might help with your constipation. Exercise, so if you're moving, that helps your bowels move too, so exercise is super important. We talked a little bit about fiber here, and I'll just point out this kind of diagram on the right-hand side of the screen. So this is called the Harvard Healthy Plate. It's kind of a general idea of how we should be eating all of our meals. Half the plate is fruits and vegetables. The other half the plate is divided into two, and half of that is whole grains, and half of that is healthy protein. So we probably all need to be eating more fruits and vegetables, and that's every single meal of the day, breakfast, lunch, and dinner. In terms of medication, so this is another example. You go to the pharmacy, you're having a bout of constipation, and there's like a million options to choose from in the aisle, so like what do you pick? So just basics on over-the-counter medications for constipation. So the pictures on the left are fiber supplements. So fiber helps pull water into the stool. So the most common ones, Benefiber, Metamucil, Citrasil, essentially are all doing the same thing, which is pulling water into the stool. I often steer my patients towards Benefiber. It's tasteless, and I find that it causes less bloating. I will say the instructions on all of these tell you to take a lot. So they usually say multiple teaspoons a day. Start slow and work your way up. So maybe start with 1 teaspoon a day. Otherwise, you're going to get bloated right off the bat, and these aren't going to work for you. The other thing that you'll see in the pharmacy is Miralax. So Miralax is a really good over-the-counter medication. It is not a fiber supplement. It is an engineered product. It basically pulls water into the bowel better than fiber supplements, and it can work really well and is over-the-counter. There's a number of other products, stool softeners, stimulant laxatives, prescription laxatives. I try and keep my patients off of stimulant laxatives, so sometimes you hear laxatives and it gets kind of a bad rap. Stimulant laxatives are the ones that your body becomes dependent on. So once you start taking them, your body continues to need them. And so we try and use those very sparingly and not for long periods of time. This question comes up all the time, should I take a probiotic? So we talked a lot about data tonight. There is no data about probiotics. They have the best marketing campaign of any product out there. There's no really good data. So studies have not shown consistent benefits. They have variable components. I think this concept of the microbiome is fascinating. We don't know enough about it, and so we can't tell you exactly what bacteria you as an individual needs to put back into your GI tract to make everything work well. So it's a great idea. We just aren't there yet in terms of data. What I tell my patients, eat a healthy, well-balanced diet, fresh fruits, fresh vegetables, whole grains, and that's going to put healthy bacteria into your gut. The last part of my talk is on colon cancer screening, okay? So in 2023, colorectal cancer was the 4th leading cause of new cancer diagnoses, and it was the 2nd leading cause of cancer-related deaths. So colon cancer screening is incredibly important. There are slightly higher men than women in terms of new diagnoses, but women get colon cancer. So we're all gonna need to be screened for colon cancer. This is a picture. So the top left picture is what a polyp looks like. When we go in and do a colonoscopy, the goal is to find these polyps and remove them so they don't become a colon cancer. That bottom right picture is what a colon cancer looks like. It's ulcerated, it's red, it's angry. That's what we can prevent with a test like a colonoscopy. So when do you start? So the guidelines changed maybe a number of years ago. So we're now starting at 45, it used to be 50. So everyone should be aware, you should start at 45, not 50. If there's a family history of colon cancer, you should start early. If there are symptoms, go see a doctor, okay? Even if it's a little blood on the toilet paper, get a colonoscopy. You don't want to miss on that. You don't want to miss out on that opportunity to prevent more significant disease. The incidence of rectal cancer in particularly is rising in people under 50, so definitely talk to your doctor even if you're young and are having symptoms. When do we stop colon cancer screening? This is my favorite conversation. So I do a colonoscopy in someone over 75 and they're like, do I need another one? And I'm like, well, the guidelines say after 75 you can stop screening colonoscopies. There is a caveat to that. The guidelines from the U.S. Preventative Services Task Force says the decision to screen for colorectal cancer in adults aged 76 to 85 should be an individual one, and taking into account the patient's overall health and prior screening history. So if you're over 75 and you've never had a colonoscopy, you probably still need a colonoscopy. But if you're, around 75 or if you're over 75 and you've been getting them routinely and you've never had a polyp, you don't have any family history, per these guidelines, you could probably stop. So options for colon cancer screening, I've talked about colonoscopy. This is a picture of what it is. It's a long tube with a camera at the end so we can directly visualize the colon and remove lesions and take biopsies. I think colonoscopy is the best test because it is not only diagnostic, it is therapeutic, so we can find something and we can treat it. Colonoscopy is not for everyone. There are many reasons people don't want to undergo a colonoscopy, so there are alternatives. So if you, in your mind, are like, I'm never getting a colonoscopy, that doesn't mean you can't be screened for colon cancer. So there are really good alternatives, common ones. So there's the stool-based testing, so the FIT test or Cologuard. I call these the poop in a cup test. You poop in a cup, you mail it back to the company, and they tell you if there's signs of potential colon cancer. There are also blood tests. There was one that came out a few months ago that got approved by the FDA. They haven't really hit prime time because their sensitivities are not great, but there are blood tests that are out there that you've probably read about. And then the last one that I'll mention is a CT colonography. There is a CAT scan test. It still requires a bowel prep, which is why people don't like colonoscopies, and it's not therapeutic. So we can find things, but then you're going to wind up with a colonoscopy if you find something, and then you've done 2 bowel preps, and then you really don't like me. So just get your colonoscopy. This is the Cologuard. That's the poop in the box test. Oops. And, so the last thing I'll mention about colonoscopy, I have a little picture there. So SUTAB, so the preps for colonoscopy, that's what people don't like. That used to always be these, like, terrible liquids, and there was a lot of liquid, and it made everyone nauseous, and like that's why people didn't want to come for a colonoscopy. If any of you have had a colonoscopy with me, I tell you, the first thing when I come to consent you is I say the hard work is done, because I know there's so much hard work that it takes to get to the colonoscopy. And so SUTAB, I think, is really a game changer. It's pills, it's not a liquid, so I think patients are generally much happier with the SUTABs. I will put in a plug. So this is our outpatient endoscopy center that opened about 2.5 years ago. It's on Baker Avenue. It's state-of-the-art. It's beautiful. Our staff there is awesome. Our center received the Press Ganey Award for Human Experience, which puts us in the top 5% for patient experience. We're the only center in Massachusetts to have received that. It's a really great place to come for your colonoscopy. So I will leave you with this, my top 5 lifestyle tips for a healthy gut. So 1, eat a high-fiber diet. 2, drink water. 3, exercise. 4, find healthy ways to manage stress. I'm going to put in one plug for a book that I've read that I think is amazing, and I'm in a room of women, so I'm going to share this with you. There's a book, and Chris started this conversation with, we all have this mental load. We're all constantly in our heads thinking about everything that's going on around us, and how do we manage that as women, as caretakers. There's a book that I read called Fair Play by Eve Rodsky. It's really awesome in terms of how do you manage your home life just like you manage your work life. And you don't need to be in control of everything going on, and you don't need to be responsible for everything going on in your home life. It has changed my life. I think it's a fantastic book. I recommend everyone read it. And number 5, get your colonoscopy on time. Thank you guys for listening.